So firstly, we'll be discussing the fluid. So they have suggested that fluid intake of 150 to 180 ml is enough to achieve appropriate nutrient intake. Though 135 ml, if nutritional requirement is met, is sufficient to maintain the body homeostasis. And in preterm babies in which growth is compromised, we can even go up to 200 ml per kg per day. It is safe depending on current clinical status of the baby. So there is insufficient evidence on benefits of whether we can give higher fluids more than 200 ml. And this thing is more important in countries like ours, in which HMF is not that readily accessible to the patients, and in the babies who do not tolerate the full strength fortification. Next is protein. So they initially in the last paper, they have recommended 3.5 to 4.5 gram protein per kg per day, but now they have reduced to 4 gram, and 4.5 can be given in the babies in which there is suboptimal growth. Then they have conditionally recommended plasma urea monitoring at regular intervals, though intervals are not suggested at what time you have to do that. In a low urea, if it is less than 16, you have to increase protein uptake up to 4.5 gram per kg per day. And if urea is more than 34, we should consider decrease intake. So this use of urea to guide protein intake is very limited and is not very reliable. And third thing, they have no specific recommendation for additional supplementation of glutamine, arginine, and taurine to decrease the neonatal morbidities. So what fortification we are giving in our country with Lectodex and this high gem available in our setup, protein intake is 4.4 gram per kg per day. Coming to energy, the resting energy expenditure for the healthy growing preterm is 60 to 70 kilocalorie per kg per day. Last ESPHGAN, they took it as 45 kilocalorie per kg per day because they did not include energy cost of tissue deposition for growth. So the total energy intake for a growing preterm is 115 to 140 kilocalorie per kg per day. And we can increase it up to 160 kilocalorie per kg per day after protein optimization, where growth is below the expected range. Then protein energy ratio, it is equally important, and the ratio is 2.8 to 3.6 gram per 100 kilocalorie. And there can be, like, if protein and energy both are low, the ratio will be normal. Again, if protein and energy both are high, the ratio will be normal. So we should target a normal protein and normal energy intake along with normal protein energy ratio, so that a free fat mass that can grow in the baby. So coming to fat, there is not much changes, and they have limited data to define if there is any benefit of icosapentaenoic acid supplementation. So with fortification, we are giving a protein intake of fat intake of 7.1 to 8.6 gram per kg per day is met. That is as per the recommended guidelines. Next is carbohydrate. Though there is no optimal intake range that is defined, but it is suggested that carbohydrate given in fortified human milk at the upper range is safe, and that improves in hospital weight, length, and head growth. So preterm formula, preterm babies fed with formula, they require low carbohydrate intake. Then the babies who are fed with fortified human milk, because there is glucose polymers in formula and they are better absorbed as compared to the lactose in human milk. So the carbohydrate intake is 11 to 15 gram per kg per day, and we should we can go to higher range of carbohydrate for a short period of time to facilitate that catch-up growth during the period when there is dip. And we should not, provided the baby is euglycemic, and we should not keep on increasing high carbohydrate, because that will lead to overnutrition, and that will again lead to increase in the fat deposition. So we are basically striving for a healthy weight gain. So carbohydrate intake in the fortified feed is 12 to 15 gram per kg per day. That is according to the recommended guideline. So next we are coming to micronutrients. So this is a study done in which they have compared PDHM composition with preterm mother donor human milk. So this is the recommended intake, and this is the mean value. And as per this, we'll be discussing one by one. So coming to sodium, so it was concluded that breast milk with added fortifier is not sufficient to meet the sodium needs in preterms, because they are more susceptible to develop hyponatremia because there are urinary sodium losses. So enteral administration of sodium chloride, it exposes the gut to higher osmolarity. So these additives should be divided in between different feeds over 24 hours to maintain the osmolarity as low as possible. And the recommended range is 3 to 8 millimole per kg per day. But in this paper, they have not recommended anything regarding when and how should we measure, and there is no clear approach to identify hyponatremia and supplement sodium. So one of the study done, they have taken urinary sodium losses to decide whether to supplement sodium or not, and they have done it at first 2 weeks and then regularly every 2 weeks, like fortnightly they did it, and then supplemented with 3% NaCl. Similarly, chloride intake, that is almost parallel sodium, where oral salt supplementation is used, and we should strive for a higher chloride intake, because otherwise it would lead to metabolic acidosis. And chloride intake recommendation is similar to sodium, that is 3 to 8 millimole per kg per day. Coming to potassium, basically potassium needs and protein retention, they have a linear association. Like we should increase potassium if there is increased protein intake. So potassium requirement, that is 2.3 to 4.6 is recommended. And we should consider upper range of potassium intake in growing preterms, receiving upper ranges of energy and protein intake. Again, when and how to measure potassium is not recommended, because even if there is intracellular potassium deficit, the extracellular potassium will be maintained. So we do not know whether intracellular deficit is there or not. And that is the main thing which is like related to this growth of the baby. So coming to calcium and phosphorus, we do not really know how to assess the bone mineral density in clinical practice, like whether we should go for calcium phosphorus or we should go for scans or something else. So there is no consensus on that. So it is suggested in this guideline that even before fortifying human milk with multi-component HMF, we should go for fortification with phosphate, because phosphate is important. So in this guideline, phosphorus intake has been increased 70 to 115 mg per kg per day. In last guidelines, it was 60 to 90, and calcium is 120 to 200. So a recommended molar ratio should be less than 1.4. And regular calcium and phosphorus monitoring is recommended, and bone imaging is not recommended. So our unit policy is to screen for osteopenia of prematurity at 4 weeks, and then every 2 to 3 weeks, depending on the condition of baby. So what Fortify we are giving, in that calcium intake is 157 to 223 and phosphorus is 79 to 112, which is among the recommended range. So coming to iron, every VLBW should be given iron, and the duration, like we should avoid prolonged dietary intake of iron more than 300 mg per kg per day, because that can lead to increased iron in the body. And in this guideline, serum ferritin, routine serum ferritin monitoring is suggested, though when to do this is not actually suggested. So if the level of serum ferritin is less than 35 to 70 microgram per liter, we should go for increase in iron intake up to 6 mg per kg per deciliter. And if ferritin is more than 300, we should withhold supplementation, provided there is no inflammation or liver disease going inside the baby. So practical tip is iron intake we are giving in fortified feed that meet the recommended daily allowance of the baby.
Kiran, sorry to interrupt, but somebody is having his or her dinner and we can hear the crinkle of the crockery. Kindly mute yourself except the speaker. Yeah, go on, please.
Coming to zinc, recommended intake is 2 to 3 mg per kg per day, and we should consider measurement of serum zinc in preterm babies with poor growth and low ALP levels, especially if there are excessive GI fluid losses, like the babies with colostomy or something else. The problem with zinc is that what fortification we are giving in our country with Lectodex or HMF, that does not meet the requirement of zinc. So multivitamin drops 1 ml per kg, 1 ml per day should be added to meet the requirement, along with other water soluble vitamins. These are the recommended levels, and this level is met with what multivitamin drops we are giving in our country. Coming to fat soluble vitamin, there is no change in vitamin A recommendation. There is change in only vitamin D recommendation, that is 400 to 700 IU per kg per day. Initially, it was suggested that we should give 800 to 1000 international unit per kg per day. But as per the study done, I have mentioned this study, effects of vitamin D and phosphorus supplementation on calcium retention in infants fed banked human milk. As per this study, they have concluded that 400 to 700 international unit per kg per day, it meet the requirement of baby. With fortification, 700 to 960, that is around 1000 international unit per day is given to baby. So now coming to the feeding practices, a very conflicting topic. So as per this guideline, they have suggested that minimal enteral nutrition 12 to 24 ml per kg per day without advancing the feed volume for a period of 3 to 7 should be given. And then we can start with a small volume of enteral feed as soon as possible and advance the feed as clinically tolerated by the baby. And more than day of life 4, a faster feeding progression, that is 30 ml per kg per day, it does not increase the incidence of NEC as compared to the slower advancement, that is 15 to 20 ml per kg per day. So what they recommended is routine daily increment of 18 to 30 ml per kg per day can be done, especially in the breast milk fed babies. And routine gastric residual aspiration is not suggested, and abdominal girth is also not suggested. If there are any symptoms of feed intolerance, then only they can see how much is the gastric residual, though there is no consensus on how much is more, and how much abdominal girth increment is can be defined as abdominal distension. This abdominal distension and feed intolerance has to be defined individually by each unit as per the clinical condition of the baby. Here we'll discuss NNF CPG guideline also. They have also not suggested abdominal girth measurement and pre-feed gastric residual estimation in all the babies. If there is any symptom of feed intolerance, then we can go for it. Now, how we should initiate and advance the enteral feed. What ESPHGAN says, we have already discussed, and it is a bit different from what WHO and NNF suggest. WHO says that we can hike the feeds rapidly, like 30 ml per kg per day, and NNF even suggest a higher increment, that is 30 to 40 ml per kg per day in stable preterms. WHO tells that we can start feed right from the beginning, from day of life 1, if baby is stable, and NNF also suggests same. So there is a big difference in what WHO and NNF suggest. Now, whether we should go for MEN or ETEF, it's very difficult to comment. But what ESPHGAN says is prolonging MEN up to 4 days may have an advantage over early advancing enteral nutrition in terms of avoiding NEC and improving daily weight gain. And it is unclear whether maintaining minimal enteral feed for several days has any advantage compared to initial early progressive feeding. What other study says is ETEF, it results in early attainment of full feed and reduces the risk of sepsis and duration of hospital stay without increasing the risk of NEC. So our unit policy is to start with early enteral feeds in stable preterms from gestational age of 27 weeks. So this is a study done in Department of Neonatology in our hospital, and it suggested the same, that there is better weight gain, there is no difference in feed intolerance, and there is like hospital duration stay is reduced. So basically there is a thing, like when there is transition from parental to enteral nutrition, this is the critical period where there is cumulative nutrient deficit and poor growth. So it is recommended that there should be a standardized feeding policy in every NICU to avoid nutrient deficit. That define that duration of MEN, that defines the daily advancement of milk feeds, definition and management of gastric residuals, definition and approach to feeding intolerance, definition of full enteral feedings, and breast milk fortification strategy. What should be the mode of feeding, whether NG feed or OG feed? Both have their disadvantages. Like NG feed, it increases the nasal airway resistance, it accelerates the work of breathing, which leads to pharyngeal airway collapse. On the other hand, OG feeding, it leads to vagal stimulation and bradycardia. So they concluded that there is no preferential method between NG and OG feed. So what should be the frequency of feeding, whether we should go for a bolus feeding or continuous feeding? So bolus feed, it promotes the cyclical release of GI hormones that stimulate gut maturation and motility. And it also increases the splanchnic perforation more than continuous feeding. And what in continuous feeding, there is low energy expenditure and a longer time to reach full enteral feeds. So it was concluded that bolus feeding is more preferential than continuous feeding in preterms. So when to start with oral feeds? Here, oral feeds means a spoon feed or breastfeeding. So individualized cue-based feeding should be preferred, though there is no consensus or a strong evidence for it. And oral feeding is a bit challenging in babies on respiratory support because there is risk of microaspiration in BPD babies. Another thing is NNS. If we establish NNS prior to oral feed introduction, it may reduce time to reach full oral feeding and decrease the length of hospital stay. And introducing oral feeding, it should be guided by the competence and the stability of a preterm baby and may be started from 32 weeks postmenstrual age. Coming to growth, we all know that during first 3 to 4 days, there is ECF contraction and it leads to weight loss of 7 to 10% in AJ babies. And it was a common notion that SGA should not lose weight, but they may lose weight up to 4 to 7%, that is lesser than AGA babies. And what should be optimal growth velocity that optimizes the outcome in preterm babies? It remains unclear. So as per WHO, in utero growth fetal weight gain decreases from slightly above 20 gram per kg per day at 23 to 25 weeks of gestation to about 10 gram per kg per day at term age. So what should be the aim for nutrition of preterm and low birth weight baby? It is to achieve postnatal growth that is similar to normal fetus of the
I think you are muted, Kiran.
ma'am. Actually, I'm not able to allow ma'am to enter from waiting room, though I have disabled the waiting room option.
Okay, shall I send the link to ma'am again?
Yes, ma'am. I'm extremely sorry for the disruption. Ma'am, should I continue?
Continue. We're trying to actually add in, ma'am. We'll see you continue.
Okay. In our unit, the babies who are NPO or on MENPs, we do oral mouth painting with colostrum. So coming to mom versus donor human milk, ESPHGAN strongly recommends mother's own milk as the first choice of feeding in both preterm and term babies. And if there is insufficient mom, then fortified donor human milk is conditionally recommended over preterm formula milk in preterm babies that are less than 32 weeks and lesser than birth weight is less than 1.5 kgs. WHO also suggests same, and NNF has a similar is having similar recommendation. So in our unit, though we have a milk bank, but still we strive to give mom to all the babies because This DHM is not an alternative to MOM because MOM does not contain these macro and micronutrient, but other immunologically active factors are also present in MOM, which helps in the growth of a baby and protects them against infections. Coming to the osmolarity part, there is no defined upper safety threshold for the enteral feeding of preterms, but when supplements or other feed additives like HMF are added, they should be added to the largest possible volume of the feed. And where breast milk fortification is required, this multi-component fortifier should be used in preference to multiple individual nutrient supplements. And in case if human milk is not available, then hydrolyzed protein may be used for early enteral feeding in preterm infants. Then coming to the fortification of breast milk, this use of multi-component fortifier products, they enhance the nutrient content and promote the growth in babies. They recommended to start fortifiers when enteral feed reaches 40 to 100 ml per kg per day. Though this minimal volume of 40 ml per kg per day will not meet the protein requirement of the baby. And individualized fortification strategies like adjustable and targeted approach may be appropriate. And still there is insufficient evidence to recommend the routine use of human milk derived fortifiers till high quality data is available. In our unit, we start to fortify this human milk, either PDHM or MOM, at 100 ml per kg per day. So WHO, although ESPHGAN strongly recommend fortification, but WHO does not routinely recommend fortification of human milk, and it may be considered for the babies less than 32 weeks and those less than 1.5 kgs. And NNF, they recommend fortification in babies less than 1.8 kgs and when enteral feed is 50 to 80 ml per kg per day. So the key take-home messages are every unit should have their own feeding policy. Not only protein, but energy and their ratio, they are important for the growth of baby. Sodium, potassium, calcium, phosphorus, they are all vital for the growth of baby, not just these macronutrients. And in this newer guideline, they have recommended phosphorus should be added, followed by this HMF fortification of milk. And while giving iron, the ferritin should be used to titrate its administration. And vitamin D, it should be given per kg per day instead of a fixed amount that we were giving initially. And we should go with early enteral feeding in all the stable babies, and MOM is the best thing to give. And others are just for the time duration when MOM is not available or the output is not adequate. Thank you, everyone.
Yeah, thank you, Kiran. I think there were 2 or 3 questions in the chat box. Would you like to answer those? How do you do colostrum paint, and
Yes,
how to detect early UGR? So could you just elaborate on our unit protocol? Then I'll add on, and Dr. Gunjana, Dr. Gunjana can also add on.
okay. So how to do colostrum swabbing in oral cavity? In our unit, we are asking mothers to send colostrum, and after proper hand washing, they just with finger they apply colostrum all over the oral mucosa and on tongue also. This is how we are doing this colostrum painting in our unit.
So just to add on what Kiran you have told, it is although there is not much of the studies on the oropharyngeal mouth painting, but as far as the studies which is being there, they have used mostly 0.2 ml of the colostrum every 2 hourly, and then they have painted in the oral mucosa. So 0.2 ml was most of the studies which they have taken as a amount or a quantity to be put in the mucosa of the baby. So another question which is there any take on how to detect EUGR early? Would you like to answer this, Kiran?
Yes, ma'am. I think the only way to detect it early is doing proper growth monitoring weekly.
Yeah, any
Because
deviation from any deviation in the weight loss pattern. What we follow in our unit is that any deviation from the normal weight loss, which has to happen in the first 7 to 10 days, if it is there, we actually try to find out the cause, whether it is evaporative losses, heat loss, any other underlying cause, and if it's not, then whether the mode of feeding has changed from orogastric to palliative feeding. So all these are the common causes, and we act early upon that. And I think the crucial time is the first few days, in which if we actually do aggressive feeding, the birth weight regain is actually good in our experience. Dr. Gunjana, would you like to add on to this?
Although the EUGR itself, it has a lot of fallacies associated with its definition. So there is one paper by Goldberg et al., which was there in 2018, and they have stated some primary indicators of malnutrition in the preterm infant. And in their consensus statement, they have said that if there is a decline in the weight for age Z score, and if there is a low weight gain velocity, as it is already told by ma'am, and they have stated that if they have got a consecutive days of protein energy deficit, which is less than the required requirement to maintain the desired growth. So these they have taken as a primary indicator as a screening tool. Although it was a small population study and the things still need to be validated, but these are the primary indicators which they have taken as a screening tool just to screen the babies for a preterm malnutrition. Kiran, another question for you. Vitamin D supplementation per kg is recommended till what age? And is there any upper or higher limit of vitamin D supplementation?
Okay. So these guidelines are up to this pre-discharge thing. So though they have not mentioned till what age this per kg is recommended, but this higher limit they have defined, that is 1000 international unit. So if 1000 international unit is has been met, I think there's no rule of per kg then. That is the highest dose.
So Kiran, what you told 1000 was actually correct, but the per kg doses, that is 400 to 700 international unit per kg per day, in the statement paper itself, they have said that this is a recommendation during the first month of life. So 1000 is the maximum, but the duration for this is 1000. For this is 1 month during the first 1 month.
There are a few more questions, Kiran. Yeah.
If the baby not gaining weight, the maximum can be increased to 160. Yes, they have already mentioned in this paper that you can go up to 160 kilocalorie per kg per day if a baby is not gaining weight.
So what does stable preterm mean for ETEF in neonates more than 28 weeks?
Sorry, I don't get the question.
So basically, I think the
how you are defining stable preterm?
Yeah, how are you defining
Yes.
stable and what is ETEF? Yeah, you can elaborate on that, no?
Like what we are doing is, if a baby is hemodynamically stable, then we are starting with early total enteral feeding. That is the only thing we are looking at. Like if the baby is having RDS on CPAP or even intubated, we are like giving total enteral feed only.
So, yeah, what is ETEF? You can elaborate on that. For that particular day, whatever is the maximum feed, we are
That's
starting with that. Okay, and
like if
stable, except for the presence of shock, I think we are giving full feeds in, as Kiran said, in all other situations.
So when to add phosphorus?
this is not very clearly defined in these recommendations. Even I'll have to see it. I'll get back to you once I find the answer.
Yeah, take the next question. How to meet calories and proteins in fluid restricted babies?
I think like in the very first slide in which we have defined the fluid intake, they have mentioned that even with the fluid restriction thing like 135 ml per kg per day, calorie and protein requirement can be met by adding this HMF thing.
So
If
basically,
babies,
the baby is fluid restricted. What you can do is, at least to some amount, we can maintain the carbohydrate content by giving a appropriate amount of glucose infusion rate, and if possible, the amino veins and the lipids. So whatever is the best possible for that restricted amount that could be given. And as soon as the baby is stable, the things could be hiked on as soon as possible. So basically, when we are restricting the baby from the fluid, that will be the time when the baby is quite hemodynamically unstable. So that's why the fluid has been restricted. So once the baby, you think that the baby started improving, you can build up on your calories and protein as soon as possible. But as soon, by the time when the baby is restricted on the fluid, at that time, what you can give is appropriate amount of glucose infusion rate, which is appropriate for that baby. And secondly, you can just add on to the amino vein and lipid to whatever extent you can.
Yeah, another condition in which you can you want to give calorie dense, or you would want to give calorie dense fluid restricted in BPD, established BPD. Sometimes we do tend to intend to give calorie dense but fluid restricted. So in those cases, you can continue your fortification since the baby is growing, and presumably, except for the BPD, the hemodynamic stability would be there. So these are the two conditions. One is the sick baby, in which because of any other reason you want to restrict fluids, like AKI or edema, whatever reason. And the second would be established BPD. In those cases also, you want to give calorie dense. So what we used to do is, make it calorie dense by fortification. So that is what we can do. You can take the next question, please, Kiran.
if baby is on full milk fortification, is it necessary to supplement multiple except? As per these guidelines and as per our own experience, zinc is very important for the growth of baby. So it is necessary to supplement the baby with zinc, even if
I think,
other.
yeah. Yes, Kiran, I think we did the nutritional audits also, and in a way, Subhash is right that if on full fortification, other vitamins are actually met, but zinc is mostly left deficient. But you have to supplement zinc, as Kiran is saying, that you need to give all the vitamins as per the RDA. So we do supplement using the multivitamins.
So next,
Gunjana, you want to add on?
no,
Yeah, you can take the next question.
next
Next
question.
question.
Do you consider weight gain velocity or crossing the centiles?
Basically, we consider weight gain velocity.
So the
Yes, velocity. Yeah.
So both the things are actually interrelated to each other. If you have a good weight gain velocity, the centile lines will be automatically met. But overall, if you have a good weight gain velocity, we do consider that the baby's neurological development, and if the baby has gained the birth weight up to 7 to 14 days in between, if it's extremely low birth weight, baby has gained the weight by 10th or 14th day. So this is one of the indicator that if the birth weight is regained by 10th or 14th day, the baby might not have the EUGR problems or other associated neurological problems. So either of the two things are interrelated, either can be followed. If you have a good weight gain velocity, the chances are less that the centile lines are going to fall off. So coming to the next question, Kiran, when to stop supplements in preterm babies, and at
Preterm
what
babies.
PMA and at what weight cutoff?
Okay. What we are following in our unit is 40 weeks PMA or 2 kgs.
Or if both are met, whichever is later. That's what.
Whichever is later. Yeah, whichever is later, you have to follow that. Yeah.
So coming to HMF recommendation, Kiran, is it a strong recommendation or a weak recommendation?
You can, yeah, I think she did show in the slide. You can maybe, it was covered in the presentation. All the 3 guidelines, the level of evidence was mentioned.
It is grade of recommendation C, which is not that strong. But yes, it is not that weak also.
So the reason behind this would be that there is definitely short-term gains which have been documented with fortification, including increase in weight length at discharge, but the long-term, they have not been translated into long-term benefits. So perhaps that is the reason that most of the guidelines, they have a little weaker level of evidence. Yeah, ma'am is also there. Sushma ma'am, would you like to add on Dr. Gunjana?